All right, hey everyone, welcome to our live session for tonight where we're talking about overdoses and toxicological emergencies. Let's get through some of our housekeeping things and then we will turn this over and get started. So as always, our live lectures are rated E for everyone. That has nothing to do with the vulgar content of our lectures. It's more or less to do with the levels of care that we're talking about. So we are going to be covering plenty of BLS stuff. We do throw a little bit of ALS stuff in this lecture because it's needed, but our live lectures will always be aimed at all of our providers. Our disclaimer, as always, is this is not protocol based. This is information. We might talk about procedures and or patient care things that may not be accepted in your protocols. Tonight, we're talking about Mark 1 or 2 PAM injections. So if your protocols don't allow that, then obviously operate within your protocols, not what is on the screen. But if you do want some information on how to get those protocols changed, you can reach out to us at the info@emsconnect.org. And of course, we can get you in contact with our speakers and or Dr. Dirks, who can help you get some of that information to your medical directors to get those protocol changed. There is our contact information, info@emsconnect.org. You can find us on social media, Facebook, Twitter, Instagram, or if you're not a member and you're looking to get a membership, www.emsconnect.org, also where you'll find all of our refresher programs as well, which we'll talk about at the intermission. We will give away our Amazon $50 gift card tonight to a random winner. Make sure you stay. I think we should make it a rule that you still have to be logged in at the end of the lecture to win. So we're going to make that a new unofficial rule. I will select randomly from the participants who are still involved with the webinar at the end who will win the Amazon $50 gift card.
That's valid.
As always, I'm your host, Sean Pitts, Head of Education here at EMSconnect, as well as host of the EMSconnect On Shift podcast. If you're not familiar with that, we'll talk about it at the intermission, but I'm also a firefighter advanced EMT here in Spokane County. I have the absolute pleasure of hosting at the last minute, Dr. Travis Dirks. Welcome.
Yeah, thank you. I don't have a beard like Edmunster, but
no. Oh, that's who was supposed to be
exactly
here. Weird. Yeah.
Yeah, Dr. Joel is busy in the emergency department. I'm available. So I thought, why not do an on-the-fly improv overdose talk? We're doing overdoses, right?
Yeah.
We're
thank
good. Heavens. All right. So
yeah,
I'm on the right topic.
All right.
Yeah, welcome. I'm happy to be here. It's exciting.
So we're talking about, it says our overdoses black and white. We're talking about overdoses, toxicological emergencies. So I'm going to turn this over to you and take it away.
Absolutely. So yeah, overdoses are a fantastic conversation for all EMS, obviously. So this is a good talk for BLS, ALS, and as we go through this, I'm going to do a lot of generalities. We're going to talk about the toxidromes and all sorts of fun stuff in regards to the actual drugs themselves and the findings you will see when you come on scene. We'll talk about cardiotoxicity, some pathophysiology, all that stuff. But again, I don't like super technical concepts. Obviously, if people are really interested, there's all sorts of fun information when you go look at tricyclics, tetracyclics, SSRIs, all this wild stuff that some medics really like to get into. But realistically, when we talk about the majority of this talk, it's going to be BLS level stuff about just what you see on scene, diagnosing what the toxidrome is, what the possible exposure is. And then we'll move into more of the ALS stuff towards the end. But we'll do some ECG stuff. Again, BLS providers, don't be freaked out about it. Stick around towards the end, you'll probably learn a lot. So as always, we talk about scene management. When you come on scene for an overdose, not only do I want you thinking about, what is causing this unresponsive altered mental status, you're likely on some of these scenes not going to know this is an overdose from the start. The call might go out as just an altered mental status, somebody who's unresponsive. There could be multiple people. Maybe you think it's a trauma or something weird going on. And when you get there, you kind of get that funny feeling based on maybe the patient's age, the situation, the scene, whatever you're finding, and say, oh, maybe this was some sort of exposure or overdose. So just be aware that a lot of these overdose calls, you're not aware of it till you get there, or maybe even later you found out that that person was altered because of an overdose. And so kind of have to have that heightened sense of awareness about what you come onto on scene and what you're going to see. As always, safety first. If you think there's a potential exposure on scene that you're going to be exposed to, don't enter the scene. The last thing we need is a potential fentanyl overdose or scare or multiple people affected by some ridiculous substance that you shouldn't be exposed to. So I never want any EMS provider to get hurt doing this job. That's not what you're out there to do. That's not your goal. Everybody wants to be a hero, but it's not worth dying at the end of the day or not being able to work the rest of your life. So be aware that when you assess the scene, there are going to be all sorts of hazards, okay? And be aware that you might want to put on a mask. You may want to put on something even heavier to avoid any potential airway issues or inhalants. And then decon is a big issue when we talk about these things. Now, so Sean, decon on scene, how easy is it to get for most agencies, especially in the rural setting? If you come on scene, you're thinking about a big powder type exposure and you need decon, how quick in the rural setting can people get decon stuff set up?
It takes a little bit of time. Most of it's just gross decontamination, getting the large, particles off of our person and off of our equipment, and then most of their decontamination is going to be done, more of a fine or more in-depth decontamination done later. But it down and dirty, right? Brush all the powders and stuff off of you that you can. Obviously, if we're talking about, whether it's fentanyl or whatever the case might be, unknown white powdery substance, getting it off your skin as quick as you possibly can is the answer. Your safety comes first.
And water's your friend on most every kind of potential exposure. So hooking up a hose, doing kind of basic decon, whatever you can do on scene is a good idea. So pre-hospital care, as always with a lot of this stuff, especially with the ODs, we're going to do the simple ABCs. And when we come on scene, are they altered? Well, if so, are they breathing adequately? And if they are breathing adequately, do we need to make them breathe more or not? So a lot of people, the topic of interest and debate is, when do we give Narcan? A lot of people come on scene and see that altered individual who's not responding appropriately, and people want to give Narcan to fix the situation. But just be aware that sometimes fixing the situation can cause a bigger problem. And so your question shouldn't be, are they awake enough for my liking? It should be, is the patient adequately stable? Are they breathing adequately? And if they are, maybe you don't need to do a full reversal. Maybe you need to keep them as they are, monitor them, reverse them if need be, if they get worse or not breathe adequately. But transporting a relaxed, slightly sedated individual is a lot more comfortable and easy and avoids problems than transferring like a 600-pound gorilla who's out of control. So using your antidotes when appropriate is quite key, and it's a good style point, and I'm big on style points when you're doing patient care. Poison control is always your friend, and everybody should have that number available, the 1-800 number available throughout the United States. It should be the same. And getting your local poison control on the phone if you're concerned about an exposure. Again, with that, one really nice style point is if there is a potential for an overdose or some sort of substance, and there's like bottles on scene or pill bottles, anything like that, bringing in stuff you find on scene is really important so we can figure out what they potentially were exposed to and maybe call poison control ourselves. And then we talk about activated charcoal for patients. If you think that this ingestion happened within an hour, the activated charcoal is very helpful for nearly all ingestions. And it's just charcoal binds things. That's all it does. Carbon likes to bind stuff. And so that's why we give it for most ingestions, because it will bind most things. There's a lot of chemicals out there that you won't be aware that charcoal might not bind them. Some of these ingestions actually require dialysis emergently. But activated charcoal, if within an hour of ingestion, and that's only for awake patients who are breathing, can guard their airway.
So with poison control, I mean, you read in the textbook, right? Call medical direction and then poison control. If I call you in the ER, I mean, you're going to tell me, did you already contact poison control, right? Poison control can be our first point of contact.
Correct.
Is that correct?
Correct. And I think that's a good thing to do nationally. Like we're teaching nationally here. So whether you're Spokane County or some county in Georgia, it really doesn't matter. For an overdose or potential exposure or some sort of substance you came across where maybe they drank out of a Drano bottle, calling poison control is really a good first step, because the physician you get on the phone is not going to know the chemical better than poison control, frankly, and they're going to give you a better idea. Now, I would default first to do what you need to do first to save the patient. So if they're not breathing, you take care of the airway. I mean, it's basic ABCs first, and then when you feel like you've kind of got a stable scene and you can take a time for a phone call, go ahead and make the phone call to poison control first.
Got it.
Absolutely correct. Let's jump into toxidromes. So these are kind of fun because it's a bit of feeling like Sherlock Holmes. I like overdose cases when you don't know the ingestion and you can figure it out by just assessing a patient's body. And really, I mean, you're assessing them from head to toe, and it tells you a lot about that individual. So let's jump right into these toxidromes and talk about how do we tell. So we have several different kinds of toxidromes that people commonly hear about, from anticholinergics to organophosphates, sympathomimetics, opiates, sedatives, yada, yada. But as we go through these, the anticholinergics and organophosphates, those are kind of grouped into similar categories, if you will. Like the organophosphates, everybody always thinks of biological weapons.
Yeah.
But realistically,
Yeah, sarin
organophosphates,
gas
yeah,
or one of
correct.
those.
Far more likely organophosphates, if you come across somebody, it's going to be just your everyday farmer
Right.
who's
West Plains
exposed
of
to their
Spokane.
parathion in their shed, and they have new symptoms. So people like to talk about, oh, it's a biological weapon, it goes off, and that's what we're going to train on. You're far more likely to have an everyday exposure at a farm. The sympathometics are quite easy. Those are things that cause that fight or flight. We're talking meth and stimulants, cocaine. Opiates, if you don't know about opiates yet, wow, that's amazing.
It's impressive.
The sedative hypnotics, those are simple. The name says it all. They sedate. And the extrapyramidals are really a funny category. These are typically things associated with psychiatric medications.
All right, so here's our first poll question. This one is more just on the fun side. The phrase mad as a hatter actually comes from Mad Hatter's disease, better known as blank poisoning. So this one's more or less just kind of on the fun side. Give everyone a chance to vote and see what they think, and then we'll get into how does Mad as a Hatter kind of fall into this whole thing.
Do you know the history behind this question?
No, I literally just was like, oh, this would be kind of fun.
It's
mostly because I mean, we all know of Alice in Wonderland, right? So
Sure.
I was like, oh, this would be fun. I was gonna try to find some Alice in Wonderland reference.
Sure. No, it's a workplace exposure.
Oh,
in the old days, the people who made hats were exposed to this chemical.
How is that knowledge in your head? 63% of the people
Good
have the
enough
right
for me.
answer, which is it's from mercury poisoning.
Yeah, mercury's bad. That's why you don't want children at your home breaking thermometers and then playing with the mercury. It's a dumb idea.
We don't have mercury thermometers anymore.
Some people do.
Oh,
Some people
crazy.
do. So yeah, mercury will make you stupid. That's the basic of it.
Good to know. Look at that. 1999.
That is
PowerPoint.
exciting.
Yep, and then it goes away.
Oh, cute.
There you go. There you go.
All right, so yeah, everybody knows this from Alice in Wonderland, but the whole point is that the anticholinergics make you a little crazy. But there's an easy way to remember this, and it's all kind of fun to remember. So hot as hell, you just get febrile. Red as a beet, they get very flushed. All the capillaries dilate, you get very red skin. But they're dry as a bone, meaning you're going to actually, they don't pee. Like they're not making urine very well. They're very dry.
So dry hasn't, and not the
mouth,
skin?
And the mouth is beginning to dry.
Would they be sweating?
No.
Okay, because I'm thinking if this is our crop duster, right, who, you know, has an issue out in his farm, it's, you know,
those people are sludgy and wet and like nasty. Yeah.
Right.
The organophosphates.
That's right.
So the anticholinergics, basically your cholinergic system, this is the reverse of that.
Right. Okay.
And so you're thinking not salivary, not leaking fluids, kind of dry, the opposite. So think anticholinergics as Benadryl. What happens when you take Benadryl? Benadryl dries you out, right? You get a dry mouth, and if you take too much of it, you get goofy. People will come in with kids and elderly who they thought Benadryl's over the counter, and so it's not dangerous. And so my child was having this itching from a bee sting for the last 3 days while we're camping.
Right.
I kept giving him Benadryl. Well, now little Johnny's climbing up the walls and attacking grandma. And it's because of Benadryl. And that's a classic. We actually see it a lot in kids.
I think isn't there a current trend of those junior high individuals abusing Benadryl as a way to get quote unquote high, right?
They get mad. They get crazy. And so full as a tick, they don't pee. Blind as a bat, their pupils get very dilated and they complain of blurry vision. I can't see well. And then obviously they're acting pretty crazy. I mean, these kids will do weird stuff. I've seen little old grandmas attack their family. And it's because of Benadryl.
Got it.
Yep. Other things you could see, I'm not going to go through all of this. You can pause your screen and take a look at these. But, you know, we talked about a lot of this. Urine retention, their bowels will shut down. They get the blurred vision, all that stuff. Myoclonus, and it's like, who's going to look for that? That's basically if you wiggle their feet like push back at you, kind of jitter.
Good enough.
Hallucinations, I mean, really, that's just they're going a little nuts. And so they could have hallucinations, say they see stuff. I've had people see bats and try to climb off the bed, and yeah, they get wild. If it gets really bad, they just go comatose and they just go to sleep, and it's pretty ugly. Interestingly, I mean, these are nasty overdoses. We see them a lot. The treatment is time. You just wait for the drug to wear off. That's it.
So no matter where you're on this list, whether you're comatose, seizures, or you have the previous slide for us in the pre-hospital settings, is just transport.
That's the key with overdoses. Nearly all of the overdoses we're going to go through in the pre-hospital setting, your treatment are the basics. That's why this is a great BLS topic, because you don't need to know all this fancy stuff. You don't need to even know a lot of the pathophysiology. Once you figure out, oh, this is an overdose, You just need to give time for the substance to wear off, and you need to do the ABCs. That's truly it, because all the other crazy stuff we do for overdoses, aside from activated charcoal, is nothing. Time and potentially dialysis for the worst case scenarios, but that's still going to happen over the next few hours.
Perfect.
Yep. So pretty interesting stuff. And there's your Benadryl, okay? The most common offending agents, I would put antihistamines as number one. TCAs is the tricyclic antidepressants, which we'll actually talk about a little bit in the extrapyramidal stuff. And then you get some of these weird ones. So some of these toxidromes you'll actually see in people who not abuse, but use herbal supplements. Like, oh, I like my teas, and I go to the herbal shop, and I go to I use the Beautiful Bounty or whatever that brand is that they get over the counter at Walgreens,
right?
And they think everything over the counter is super safe. I just had one last week of a lady who had, I mean, her sodium and calcium levels were like life-threatening. And going through the whole history, I couldn't figure out what the hell was going on with this lady. And then I asked, tell me what medications you're on. Well, none. Herbal supplements, anything you take. And then she laid out this list of 10 things she's been taking for like a decade through over-the-counter stuff at Walgreens, and it totally destroyed her kidneys. So people just aren't aware that these herbal supplements and things you can get over the counter are not FDA regulated, and therefore people aren't telling you, if you take too much of this or use it inappropriately or take it for years and years and don't tell anybody, it will really F with your system and it can really ruin things. So you got to be kind of careful about this. So if we have these weird overdose cases, then it's that Sherlock Holmes. It's kind of fun of like, figure out what they've been exposed to. Treatment, again, symptomatic. It's just supportive. It's just purely supportive in the pre-hospital setting. Sure, could you give some fluids if they're dry and look dehydrated? Absolutely. Is it going to change a whole lot? Probably not. You're not going to see a lot of vital sign problems with this. Then we jump into the organophosphates. Whenever you think organophosphate, think farmer and parathion. The organophosphates, they're basically used to kill insects and humans, really, for that matter. And so, yeah, the point of this is that the organophosphate basically paralyzes the insects and kill them in certain ways. So it causes interesting toxidrome in humans. And there's dumbbells and sludge, and whatever way you use to remember this, really the general idea is think fluids, leaky fluids, vision changes, but the opposite of the anticholinergics. While the anticholinergics will cause your pupils to get huge, the mydriasis is what that's called, this causes the same thing as the opiates. They get meiosis, meaning tiny. And I just remember that meiosis sounds like it's a small word, whereas mydriasis is different. I don't know, that's how I remember it. That's how I got through med school. So you're thinking fluids and big problems with fluids. So these people are crapping their pants, got diarrhea, lots of urination. They can't see because their eyes are so pinpoint with this. Everything is slow. Bradycardic. Bronchorrhea is like fluid in the lungs and having trouble breathing. They're vomiting. Their lacrimation is they're just tearing. They're running tears, and then they're salivating. So everything with this is just like I'm draining fluid. Think organophosphates, and likely the whole scene is going to kind of paint that picture. It's going to be that ranch or farm setting, most likely farm where they use pesticides, and you're going to have somebody who just cannot handle secretions. They're having trouble breathing. Something's not quite right. And you're like, what the hell? There's like so much stuff happening, but there's no exposure. They're not talking about I got stung by a bee or anything weird. And you're like, what? Like, how did this happen? Take it, just open your eyes and look around. Oh, crap, we're on a farm. Okay, what happened here? And then the sludge is just kind of the same thing. It helps you remember it. So however you want to remember it, whether it's dumbbells or sludge, I did
add both of these to the quick facts of just some good visual looks at these because I think they're important.
Yeah, that's perfect. And so obviously think of insecticides, parathion, malathion, anything with ion, but then there are lots of other pesticides that are out there. I mean, I don't know any of them. And really your history, your on-scene history and just your open eyes and playing inspector is going to be the best thing. We talk about the nerve gases, but honestly, if a bomb goes off in a town and there's a chemical exposure, who gives a flying F what the exposure is? Get out and save the people you can.
Do you know what movie this is from in the background? I give you $1.
Hold on, let me take a look because I like movies. I can't tell what he's holding.
Oh, see, then I guess
is that
green.
Nicolas Cage?
Oh, yes.
So it's Nicolas Cage, which
holding.
Oh, it's the string of pearls configuration from. Hold on. Oh my gosh, Sean Connery, Nicolas Cage, and The Rock.
Oh, there it is. There's $1.
Yeah, baby. I love that movie. I have that movie.
That's why it's in here.
I couldn't see the beautiful string of pearl configuration.
Really elegant string of pearls configuration. Unfortunately, incredibly unstable.
Anyways, right. We digress. All right, so here is our next poll question. Should have had that as a poll question. Yeah. The use of the Mark 1 or some labels call it 2-PAM auto injector is a BLS skill, true or false? So we're going to put that up on your screen. Go ahead and vote. Maybe just what is your current protocol? Have you ever even heard of this before? We'll go with that.
I love The
no one
Rock.
heard it.
I've
It's
seen
such a
that so
great-
many.
It's a terrible movie.
Dude, best
It's
quote
so
from
stupid.
that.
Hey man, you just fucked up your Ferrari.
It's not mine. Neither is this.
That's the best part of that movie.
This one's kind of split right down the middle. So 57% say true, 43% think it's false. Yeah, so there it is. Go ahead and go to the next slide
Fantastic.
and let's talk about the Mark 1.
So yeah, the Mark 1, if you think about the cholinergic response to everything, you're lacrimating, you're diarrhea, you're urinating, you're leaking fluids, all this fluid, you want to shut that down. And so the treatment for that is atropine. So the Mark 1 is basically a big buttload of atropine, and it does the opposite. It's basically the reversal effect, not so much reversal, it just causes the opposite effect. So it dries everything up, and lets you breathe better. It takes that bradycardia of 30 and fixes it nice and quick. And you may have to redose, but yeah, it's pretty sweet.
And what's the other one? Because this is a dual
dual
auto injector. Yeah,
Yeah.
because it's 2 auto injectors.
Pralidoxime.
Yeah.
Yeah, the pralidoxime is
Just the same
basically
thing.
like an adjunctive medication to help out the atropine.
And then as in The Rock, do you stab this directly into your heart?
That's the worst part about that movie.
Oh, okay, it goes
No,
in
he
your
pulls
leg.
out that needle and puts it in his heart. That's such BS, and I hate that part. It's so Hollywooded up. So sympathomimetic toxidromes, everybody should know what this is. So the sympathometics is the things that make people get high. Methamphetamines, cocaine, MDMA or Molly, the not the date rape, but like the rave drugs.
Yeah,
okay, things
MDMA.
that they make people just get wild. And so everything about this is your fight or flight. So if you always have trouble remembering, oh, what's the fight or flight response? Remember, you're in a dark alley, somebody who pulls a knife on you, all the things that are going to happen to your body to survive. Your eyes will dilate so you can pull in more light and see in the dark like a deer, okay? Your heart rate will jack up so that you can run farther and get more blood flow going. You're going to just, everything's about running far in the dark. Everybody
I
knows
always
their
look at this and say
patients.
it mimics your sympathetic nervous system. It's not even
Correct.
a big word.
Oh
so.
yeah, it's just
it breaks it down.
Yeah, exactly. It's just too big a word to say basically meth and cocaine.
Right.
And so you're going to get sweating, your eyes are going to get big. It's going to be all the opposite stuff of the opiates is really how to remember it. They're going to be very tachycardic, breathing fast. Potentially they hallucinate, but that's not required at all. I would think the most common stuff you're going to see is tachycardic, rapid breathing, a little anxiety, pressured speech. Yeah, I mean, just basically think of the last time you saw a methamphetamine patient and this is it. Most commonly, obviously going to be coke and meth. Coke is actually coming back. I've been noticing people are doing it more. Amphetamines and methamphetamine, same class. Amphetamines actually like can be prescribed to people like Ritalin and that kind of stuff. And so it's in some over-the-counter things, and now they regulate that, you know, like Sudafed. Methamphetamine is the street drug. And then you get some other ones, ephedrine, pseudoephedrine. Pseudoephedrine, what is in Sudafed? Ma Huang, that's a drug that we don't see a lot around here, okay? But that's a street drug. And then again, treatment with this is supportive. If you want to have some style points and have a medic on scene that can give some benzos like Ativan or Versed, that is the, not reversal, but it causes, like atropine, it causes the opposite effects. It calms everything down. Opiates, everybody should have seen heroin, oxycodone, OxyContin, fentanyl overdoses by now. If you just started this job, I'm sure you've already seen opiates your day one of working anywhere in the US. I mean, this is rural, urban, everywhere. They're going to cause people to go to sleep and stop breathing is the gist of it. And so these are the people who come on scene. Bradycardia, you really don't have to rely on bradycardia. It's truly going to be they are sleepy, falling asleep while I talk to them. Their eyes are kind of pinpoint, very likely, and they're breathing slower. And your goal
And does
with
that person you just described, does that person need naloxone?
no.
No. Because why? Because they're
No.
awake.
Naloxone is another drug. And so every drug you give, you have to have a reason for giving it. Do I need to save this person's life because they're dying, they're not breathing, and I need to intubate them? Yeah, give Narcan, absolutely. Is this person a little sleepy and breathing and not a problem for us right now, but needs to go to the hospital, leave them how they are. They're a great patient. They're just a little sleepy. So watch their respiratory rate, keep them on O2 monitor, and just go with that. But yeah, don't throw Narcan at all these people unless you really want to create a big problem or fix the big problem.
Right. Well, and you mentioned, I mean, creating you have an unconscious person, you create a 600-pound angry gorilla.
Yeah.
It's not even the 600-pound angry gorilla. It's the 120-pound heroin user that's now wide awake, that's pissed off, that's in the back of your ambulance,
Clawing at you,
that could still be as
punching
dangerous
at
as
you,
the 600-pound
and
gorilla.
trying to jump out of the ambulance,
For sure.
saying I'm leaving right now.
Yeah.
I mean, it causes major problems.
Yeah. And a little caveat: if you're approaching these patients, your own safety, there is nothing wrong with doing a rapid trauma exam while they're unconscious to look for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, swelling, and weapons. And to ensure that we're not going to get, because when we wake them up, there's been cases of them grabbing firearms and knives and weapons and injuring first responders. That's my little soapbox.
Yeah, no, there's some good YouTube videos, but I think of one where he was on a bus. A guy was unconscious on a bus.
It's in our lecture for abusing Narcan. I can't remember what it's called, but yeah,
you're right.
Ends up shooting and killing a firefighter and injuring a police officer, and then tragically he loses his life as well. But
so we all know the offending agents. These are going to be all the opiates, anything that ends in codone, hydrocodone, oxycodone, OxyContin, fentanyl, all the pain medications people are on after surgery. Dextromethorphan's thrown in there because you take enough of that and you can have some opiate-like effects. And interestingly, we don't have it on here, but Imodium, the diarrhea drug.
No kidding.
Yeah. So Imodium is known to cause similar effects because of the receptor it acts on, and is the same opiate receptor. But the trouble is you have to take, an overdose of Imodium. And these people are also quite constipated, as you can imagine. But yeah, Imodium has been seen. There's been some case reports. But again, you got to take a lot. But obviously, we all know the treatment's Narcan or naloxone. It basically binds the mu receptor, the same receptor that causes the opiate effects, takes away that. And it works very quickly. You can give it in virtually any way you can possibly think of. You can squirt it in any place, use a MAD device, nasally, IM, IO, anywhere, and it will work. But remember, you don't have to go crazy with this. A good style point is going to be give like 0.4 if you can. But I understand the nasal 2 milligrams might be what else.
Well, and the over-the-counter stuff that the public is getting is 4 milligrams, so it's even more of a dosage.
And so you're talking full reversal, and you're going to have one pissed off individual who refuses to go anywhere, is now fully awake. The trouble with that is, now they are able to make their own medical decisions. They are aware of stuff. The concern is always, and the question is always, what if they walk away? Will the medication kick in again? Because technically the codone lasts longer than the Narcan, technically. I haven't seen a lot of case reports of people having to redose other than fentanyl. Fentanyl is the one to be afraid of.
Well, and then carfentanil, the synthetic side of that, right, is
any kind of fentanyl,
drastically more potent.
So those people do have to get put on Narcan drips occasionally. And so be very, very careful if it's any kind of fentanyl or carfentanil. So there's our cottons we talked about. Okay, there's some long acting, some short acting. You don't need to know what's long or short. The fact is they have an opiate overdose. You've diagnosed it. Now we know the treatment or not treatment. There's some style points to reversing it. Moving on to the sedative and hypnotic. So sedative, hypnotic, this is common sense. It's things that make people very sleepy. And so becoming sleepy can cause confusion, drowsiness. It can put you into a coma. There's other things like paresthesias, which basically means the numbness and tingling you feel. Diplopia is double vision or blurred vision, and the blurred vision can be from either small pupils or big pupils, okay? Slurred speech just goes along with being super sedated and semi-drunk kind of looking. And so these patients look drunk. And the problem is people will think they're drunk, and it potentially is they're accidentally overdosed on grandpa's medications or something else. So you got to be careful. Overdose cases are a classic situation for bias and crap decision-making because we come on scene and we assess the situation, our humanity comes out, and we just think the worst of people,
right,
when it might not be the case.
Right, checking for stroke, checking for seizures, checking their glucose, right, ruling all those things out before we stamp them with the hypnotics.
The common stuff, ethanol, alcohol is in this category because it is a sedative, and we have the barbiturates, which are kind of an old school depression calming medication. Some people do still abuse them. The benzos are all the PAM, like the alprazolam, Ativan, benzos, and all the benzos like Versed and stuff, which we have available. And then again, supportive. We just wait for it to wear off, give them fluids, protect their airway, nausea medication. Let's talk about the extrapyramidals. These are weird ones because it's not something that's common. We don't see it a lot. But extrapyramidal effects, torticollis is what we see here in the picture where people get their head turned, and basically if you think about the sternocleidomastoid muscle in the neck, and the other muscles in the neck get spasmy, and so they'll turn their head, and their head will look very stuck to one side.
This is a continuous and it stops, or is this a jerking
No,
motion?
no, it's not a jerking.
Okay.
It's a constant pull. It's like a constant tonic, and that neck is stuck there.
Okay.
And these is basically the side effect of the offending agent. You can get the ocular gyrate crisis, basically twitchy eyes, okay? You don't have to remember all these effed up long terms. Basically the nystagmus or the twitchy eyes. Interesting thing about these, you could get rotary nystagmus, where instead of sideways, which we see with alcohol and a lot of overdoses, this can be up or down, or it could be rotary, where it's going round and round. The lockjaw thing is funny. It's not so much that they're lockjaw like you think of tetanus. It's more of because these extrapyramidal, the muscles are just spasming, so they can't open their mouth very well, okay? And they just get kind of spastic, where the muscles are contracting a lot. The common offending agents for these are some of the weird ones we see with antipsychotics. So haloperidol is Haldol.
I had a Haldol overdose, and this guy and I didn't know. That's why I was wondering is he was pulled to one side with his jaw locked, and we thought he was faking. We honest to God, we're like, there's no way.
We're judgy.
Yeah.
Yeah.
Well, yeah.
We're human. Thanks. We're human. Yeah.
Yes, I was judgmental.
Compazine is a nausea medication that has some pretty nasty effects. Phenergan is also a nausea medication, and people will come in requesting these medications because it gives them a high potentially. So that's why people abuse these and why it's a toxidrome, because they can be abused or could have side effects from their common meds. So Haldol is a very common antipsychotic some people will be put on. The phenothiazines, again, another antipsychotic type medication. Treatment, again, like most overdoses, supportive. Interestingly, ultimate Benadryl, okay. So we give Benadryl because it kind of does the opposite effect.
Is that a pre-hospital standard to be able to give diphenhydramine for this? That's an in-hospital thing?
I would not do it because it's not going to fix anything right now. And I want to see that patient decide which way I want to go ultimately before you potentially give medication with other side effects.
So what if I've got an hour and a half long transport? I'm a rural agency and I have diphenhydramine. Would that be a possibility?
Oh, absolutely. If you're so astute and you've Sherlocked the hell out of this case, and you're like, we got an hour, we're on scene, or we're waiting for transport.
The patient says, I took a bunch of Haldol.
Yeah, or if you're looking at their medicine bottle and the mom says, yeah, they overdosed on this, and it's Phenergan or Haldol, and you call online medical control and give your reasons and give the description of the patient, and their head's turned and they can't open their jaw, they're weird, they're acting funny, and it's pretty obvious an overdose, absolutely, if you can give some Benadryl, that's fantastic, cool move. But again, I would do just your protocol, 25, 50, oral, perfectly fine.
Perfect.
So tricyclics. This is a complex category of medications. There's things called tetracyclic medications. The gist of it is it's named after its structure. So this is a 3 circular ring chemical structure antidepressant. You don't need to know that in any way, not even the medics or anybody. The gist of it is these are antidepressants. These are one of the first antidepressants. They're super old meds. With super old meds comes side effects. Modern medications, the goal is to get a great effect with no side effects. That's the big goal. So these medications were good antidepressant medications before the newer aged ones, but they had lots of side effects, which was the problem. Hence, the newer medications have been developed like SSRIs, the selective serotonin reuptake inhibitors, and other antidepressants. The trouble is that some people who are on the newer antidepressants don't get a good effect, and so they revert to trying some of these old school ones. And so there's actually a lot of people on these, and most of these medications end in INE, amitriptyline, nortriptyline, they all have that same ending, the tyline. But you get a lot of anticholinergic effects. And so we revert back to the other slide or look on your quick fact sheet for those. But the gist of it is with the anticholinergics, they are different than the new age because the SSRIs selectively prevent the uptake of serotonin, whereas the tricyclics are both serotonin and norepinephrine. So there you're going to get some nasty side effects, okay? And so you get sodium problems, you get the direct alpha adrenergic blockade, basically it's the norepinephrine issue. So these are less favorable because of the side effects. There you see some of the names, amitriptyline. There's other ones that don't have the toluene end, but who gives a crap? Basically, bring in the bottle with them. Or they might tell you they're on a TCA. Celexa and citalopram are SSRIs, and so, but these metabolize in a way that you can get some TCA type effects. And then we have weird things like Flexeril and cyclobenzaprine. So Flexeril / cyclobenzaprine is a muscle relaxer, but it has some properties that are similar. Lidocaine, propranolol, strange medications. I mean, lidocaine's a local pain medication we use for anesthetic effects. You might see some of these issues in dental practices. You might get called to a dentist clinic for a funky reaction after somebody got a numbing medicine in their mouth. Okay.
All right, here's our next one. Symptoms of the tricyclic overdose can be seen on a 12-lead EKG. True or false? Whether or not your agency can use that or what you think, we'll give you a few minutes to answer. Have you had people come in with lidocaine adverse reactions?
Oh, so,
is it common?
So lidocaine's scary because if you overdo it, you kill them. Yeah,
Fair.
so lidocaine technically.
Thank you for feeding my fear of the dentist.
Yeah, so lidocaine technically is a heart medication.
Right, we do give it in cardiac arrest.
Bingo.
Right.
And so it affects your sodium channels and it's used for cardiac stuff, hence the lidocaine we usually give for heart stuff. The problem is it's not usually the dentist stuff. To get an overdose of lidocaine, usually it's a very big wound. So the classic cases, and they're super rare, obviously, a clean kill with lidocaine is like the urgent care or the family clinic where they weren't quite aware of it. Maybe it was a nurse practitioner, a PA who wasn't used to large lacerations or something, and they're forced to kind of repair a large laceration, like the whole lower leg or the whole arm, and they just inject the whole thing with lidocaine to numb up the edges, and they end up clean killing by overdose of lidocaine.
Wow.
Stops the heart dead.
A majority, 61%, said true, that you could see the symptoms of the overdose. So can you see symptoms of tricyclic overdose on EKG?
Absolutely.
Well, why don't
They're
you
quite
tell us
fun.
It's coming up.
Oh, it's really exciting, everybody.
Yeah, it's cardiac. Yeah.
So these are actually one of those times as a BLS provider where I would say, hey, golly, I really want to do 12 leads because you can see some cool stuff. So a TCA overdose will cause problems with sodium channels and blah, 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 all these weird pathologic chemical stuff. And the cool thing on a ECG and a 12 lead is you'll see a widening of the QRS complex and maybe QT prolongation. And the really fun stuff with TCAs especially, and this is why emergency physicians and emergency residents love a TCA overdose, because these people are dying and because they're a heart issue and they have a wide QRS complex on the ECG or on the rhythm you see on the monitor overhead, and they give them bicarb, and you'll literally in real time watch the QRS just shorten as the screen goes across. It is really fun and really cool, extremely rare to get to see that. And so this is a super rare type of overdose. It takes a lot of stuff. It causes some interesting ECG stuff. The most common is going to be sinus tachycardia, and you get this widening of complexes that you can fix with bicarb.
So let's talk about some EKGs.
Oh, yeah, this is going to be fun. So for the BLS providers out there, first of all.
By the way, this is you in the back. This is the BLS provider in the background of the slide.
That's Sean's doing. So for the BLS providers out there, I know you guys hate it when I talk about 12 leads for BLS. I'm a big proponent of 12 leads for EMS, not because I expect you to read the weird stuff and be a cardiologist. You only need to read the top wording to say, is this a STEMI or not? That's why I think 12 leads for BLS is out there.
But I think I disagree with you. They should be able to just look at it and go, that's not normal, right? Across the board.
Sure.
Can they recognize a wide QRS and a prolonged QT? If you understand the fundamentals, at least they could go to the medic and go, I don't know why, but this doesn't look normal.
And
or
that's good.
Now's a great time to launch a helicopter because it doesn't look normal to you, or add an ALS agency because it doesn't look normal to you.
Or even better, take a picture with your cell phone, call online medical control and say, hey, can I text you a picture?
I like it.
And we can tell you right off the bat if this is a big problem.
Wouldn't it be weird if we had monitors that had Bluetooth capabilities of transmitting EKGs to the hospital and they could receive them? You should invent that. Oh, wait, it's already done. Yeah, weird.
I don't expect a lot of people to geek out on this. There are some really interesting concepts here, but we're talking the basic action potential of the heart deals with three main elements: sodium, potassium, and calcium. That's why we all get kind of scared when those are really out of whack in the human body. Potassium, why do dialysis patients die? Hyperkalemia, why? Because it F's with the heart's electricity, They get a wide QRS, everything slows down. Pretty soon you get a sine wave and they're dead. Sodium, potassium, and calcium control the action potential of electricity in your heart. That's it. That's all people have to really remember if you're a medic. If you want to pass most exams and there's a pathophys question about heart and electrophys, it's sodium, potassium, and calcium. That's really it. Sodium is the first part, potassium's the middle, calcium's the end. There's not much more to it. Yeah, you can get super technical, but the gist is if you F with any of those channels, sodium, potassium, calcium, or screw with how much there is or how little there is or how much you give them, or if there's an overdose of one of those and not available, or they're in kidney failure and can't regulate them, you screw with the heart's electricity and you kill people.
Some wives' tale about that's what lethal injection is, right? Is just an overdose of
potassium.
Potassium.
Yep.
Right. Okay.
Yep. So a lethal injection, basically the first dose is a sedative, knocks them out. The next dose is a massive overload of potassium, and they absolutely kill the patient the same way dialysis patients die, hyperkalemic death, and it's extremely efficient as long as you do it properly.
Right. True story.
So here, this is kind of funky stuff that starts to happen. Okay, so TCA overdoses, you just see that things just start to widen. Like, I don't expect anybody to be able to describe this if they call me with online medical control. I don't expect anybody to go, hey, so in the QRS complex, the Q wave's still down, the R wave looks funny. Like, no. Just this looks really screwed up to me.
And for BLS people, take 12 leads of normal patients so you know what normal looks like, and then you can look at this and go, I have no idea what that is, but it's not normal.
Yeah. So right now, all the BLS providers listening, most of them are kind of looking at them and going like, I'm not learning this. It's too technical. And I agree. This is technical stuff. But again, the reality is at the top of every 12 lead in the BLS situation on your cardiac monitor, whatever you're using, it gives you a readout and it tells you if the QRS is prolonged. It tells you if the PR is prolonged. It's not that you need to do anything about it, but it's really helpful to us when you get them here. And really my big push for why BLS should absolutely do 12 leads on every chest pain patient or short of breath patient is because it's now totally proven in the literature time and time and again that if you get the initial 12 lead ECG when the patient is, you're on scene with them, it's right away in the evaluation. Nobody's done anything for the patient yet. No aspirin, no oxygen, no nothing. And you get that initial 12 lead. By the time you and the medic treat the patient's 12 lead has changed. So by the time I see them in the ER, without yours, I don't know that their initial one looked abnormal. And so it's been proven now that 20% of STEMIs on scene are resolved by the time they get to the ER. So that means if you're a BLS provider and you're responding to chest pain and shortness of breath patients, which you are regularly, and you're not getting them, potentially a whole bunch of your patients are having heart attacks that you're not diagnosing. And by the time that the paramedics or I see them, the changes are gone and we're not treating them properly. So that's another push for it. So here's your really wide complexes. Everything's kind of starting to look funny, getting a little wider. You're getting funny waves. You get this funky looking stuff, and like V1 where this, you can't tell where the QRS stops and the 2 wave starts. It's just, it looks weird. And not that you need to diagnose this, but it's just interesting, and it tells us maybe we do need to treat them. Here's a whole bunch of things that screw with your heart. So these are sodium channel blocking agents. And you'll see cocaine, lidocaine on this list. Okay, those are some of the same categories. Local anesthetics, that includes all the ANEs, cocaine, lidocaine. Cocaine used to be used as an anesthetic every day in the old days. It's still used in some ENT offices for putting in the nose. It causes local anesthesia. It works really well. I don't expect anybody to remember all those. So pre-hospital management for TCAs, obviously supportive. Okay, you're going to give IV fluids. Bicarb, if you have that capability, call online medical control, say, hey, we got this weird EKG. It's got really wide QRS complexes. I've got a pill bottle of a bunch of amitriptyline, and we suspect the person took an overdose. I'm going to say, go ahead and give a slug of bicarbonate. You'll probably see some pretty cool effects. And the point is that it counteracts some of the sodium channel problems that you see with the TCAs. Okay, and it's really cool. The QT interval, it's basically that interval from the start of the QRS complex to the end of the T wave is the QT, and that can get really prolonged. And we teach, I don't expect people to remember numbers. It's 0.2, 0.4, I don't give a crap about the numbers. If you just remember boxes, our PR interval should be less than 1 big box, our QRS should be less than 3 little boxes, and the QT should be less than 2 big boxes. So it's pretty simple if you just kind of put that in your head and you can remember
as
it.
the EMTs download, they're all over Google, right? You can print them off of just, here is a normal QRS. It gives you the boxes. It allows you to measure. I mean, you can even buy the little measuring and put it in your pocket of your uniform, and then it's all. And most of them have little cheat sheets of just what you exactly just said. I mean, longer than one big box with 3. Like, as a new EMT or even as a seasoned EMT, use those things. That's what they're for.
And the QT prolongation, why we get nervous about that is that as it gets longer results in torsades or this polymorphic ventricular tachycardia. Huge words. It looks like VFib, VTAC, but it's doing this small waves, big waves, small waves, big waves. It looks really abnormal. The patient's dying. You're shocking them. You're doing CPR. These patients are not awake. It's not an awake patient. When their QT gets so long that they go into this VTAC arrest, and a good treatment, bicarb. We do a lot of bicarb. If we think there's a prolonged QT, I'll throw bicarb on every one of those patients. If you call online medical control, I'm hoping they'll tell you to give some bicarb. Hopefully you're given as part of your whole ACLS thing. It's not typically part of ACLS as an improving thing. It's been proven to not improve.
And they kind of started taking it out of, I mean, older ACLS, we picked up on it, but later,
definitely if you call me and you have a potential overdose situation in a VTAC arrest issue, I'm definitely going to say go ahead and give bicarb, because why the hell not? It's not going to hurt anything.
Well, and torsades to point us, right, is like if you took your EKG strip and spun it 2 different directions, it kind of looks like that. Was it turning at the points? Is
it's a twisting.
What it means,
Yeah, twisting. So this is just an example of the R to R interval, and then you have your QT interval from the start of the Q to the end of the T, and again, that should be smaller than 2 big boxes. Then we have some issues with long QT and some other issues. So people can have inherited or congenital problems with their QT, and this is more of a problem with the formation of their heart muscle itself. And you get problems with your sodium or potassium channels. So some people are born with screwed up sodium and potassium channels in their heart, and these are bad congenital problems, and these patients a lot of times won't survive. Then you can get some electrolyte problems that are induced by us, whether it's our diet, our medications we're prescribed, our herbal supplements we're taking. There's lots of ways to end up getting screwed up electrolytes. And then we have drugs like our antiarrhythmic drugs, some antibiotics, and then we have our antidepressants like the TCAs and SSRIs that can screw with these same channels. So lots of things can do this. The reality is it's not one dose. It's not when you start the medication that you're going to see these issues. It's they've either overdosed or they've been on it for a long time, or classically, oh, they just had that increase 2 weeks ago, or the dose was increased recently, and then you end up with some funky effects. So these are some of the drugs associated with QT prolongation. Again, there's an absolute ton of them, and so nobody should memorize this list. Just know that everybody takes prescription medications. Every medication, herbal supplement, anything non-prescribed, anything we take over the counter has a potential for side effects if we overdo it or if we're on it a long time, and it's hard to predict those. And so if you have a weird situation, an awkward patient, altered patient, somebody not acting right, their head's turned, something weird is happening, get some other clues. Get the 12 lead, get more of a history, ask them for all their meds, ask them for their herbal supplements, get any bottles they have of anything, and bring them in, and we start trying to put the clues together, because sometimes they're on so many things. Inevitably, when you combine them with one, the next, the other 5, cumulatively, they cause some big problems. This is a good example of torsades, and it's not classic, but you see kind of this twisting. So it's VTAC, but our typical VTAC is all the same. You just see boom, boom, boom. It's all the same, okay? But on this one, you see polymorphic VTAC. They're not all the same. It's changing. Or if you look at it, you could say, oh, is it kind of twisting around the center? Maybe, sure. But the gist is it's VTAC, but it's not the same. That's why it gets that polymorphic. It's not the same morphology. So
that's say this just looks wrong.
Yeah, it looks horrible.
It doesn't look right.
Well, and your patient would look terrible.
Pretty sick.
They're dying.
Yeah.
Okay, you're doing chest compressions on this.
If they're conscious and alert, then something's wrong.
And so again, the 12 leads will all give you the intervals. And so up here you see the QT or QTC. It means corrected QT interval, 511. You know, you can remember things like 500 is long or not. But again, I never even look at the numbers. I look at the boxes. So you pick a QRS that's on a big line, and you look at the end of the T wave. Well, does it stop within 2 big boxes? Yeah, we're good. Move on. I don't give a crap. Let's do a case review.
All right. Go ahead. What do we got?
So your case, you got a 31-year-old female, Okay, multiple previous events of self-harm attempts, including overdose, suicide attempts. Okay, so the person called the suicide hotline from home and said she had taken 20 to 25 propranolol, which is a medication a lot of people are on for like stage fright. Okay, it's a kind of a small anti-anxiety medication, classic minor medication to be put on for test anxiety and stage fright type stuff. Okay, she was going to local grocery store. A third party called to 911 dispatch regarding what happened. A friend obviously told her. She's found with decreased mentation outside the grocery store. LEO on scene and familiar with the patient for multiple previous attempts. So people know this person says, she does this all the time. Okay, there's her past history. Obviously has a depression, anxiety, prior seizures and tremors. So interesting. Is she on meds for it? Yes, she's on lamotrigine. And then the propranolol for her anxiety issues.
Don't click yet, because
yeah.
Now we're going to jump into a poll question. It's interesting because if you look at propranolol, that's what the next question is going to be related to. I think a lot of people get caught with the medications like propranolol of being a certain class of medications, and sometimes those certain classes are associated with geriatrics only. So click one real quick, because here's our class, because I don't want to give it away before we say it, but what class of medication is propranolol? Is it, laugh out loud, beta blocker, opioid, anticholinergic, or an antidepressant medication or antidepressive medication? I want to just throw that out there and just see what people think, and then we'll talk about where that's, because me personally, I always associate this certain class of medication with geriatric
Something
patients,
else,
right?
That's why I intentionally didn't say what it was. Yeah,
I'm glad you didn't.
Because it's not
almost
typical.
like we're on the same page.
Absolutely.
Yeah, that's good. I'm gonna let this one go a little bit because we're at 48%.
It's a tricky one.
And most people are not getting it right. So I'm gonna let it go a little bit, which is perfect.
That's good.
This is a great question.
And this is something you'll see a lot of people on. It's a common medication.
Yeah. And what's interesting is you said that. I had no idea that this medication is prescribed for that. I feel like I get kind of stage fright.
Yeah,
so
which you'll see a lot of young people on it because of school test taking anxiety and general anxiety, and they'll start as a minor medication that they don't have to use every day.
3 seconds. Keep talking. Sorry.
Oh, yeah.
Here's what's interesting. This is great. This is perfect. 52% of people think it's an antidepressant. 39% of people got it right, which is it's a beta blocker.
Yeah.
Which I always associated with a geriatric patient who AFib or some sort of
blood pressure problem.
Exactly. So I didn't know the question was going to go like that, but that's awesome.
Yeah, all the OLOLs are beta blockers. Sotalol,
laugh out loud.
metoprolol.
LOL. Right?
Yep. So this is a beta blocker that we use because its typical effect is it slows the heart rate. And so what happens when you get on stage? Your heart rate races and you feel palpitations, you get anxious. And so the reason why we give it for those issues is because it helps control the heart rate during times of anxiety. And if your heart rate's controlled, you don't really freak out.
Right.
And so it's a good medication. It's very small dose. It's not affecting your blood pressure so much because at the dose we prescribe.
So it just kind of suppresses your fight or flight just a little bit,
doesn't
right?
make you sleepy. It's
now, let me ask you a question. This person gets in a car wreck. Will it impair her ability to get tachycardia to compensate for shock?
Yeah. So this medication slows the heart. Yeah. And so what you expect with this patient is a heart rate that's normal or low. Yeah, it shouldn't be very high. So beta blocker and calcium channel blockers are really deadly ingestion. So what we see sometimes in the elderly, because that's the patients who are classically on beta blockers and calcium channel blockers because of their long-standing hypertension, their AFib. I mean, these are elderly issues. And so people who overdose on these are fairly successful overdoses because these are some dangerous medications and there's no real reversal for this. Okay, we have drugs like glucagon, or there's no antidote for these. The reality is if you have a severe beta blocker calcium channel overdose, the treatment is typically to intubate them and put them in a coma and basically pace their heart if you need to, or put them on full bypass. We'll put them on full cardiac bypass like you're having a heart surgery until the medications wear off, because the medications will slow your heart and tank your blood pressure, and there's no fix. There's zero things you can do to fix it. So basically, to outlast the meds, we take over the beating heart. We put them on full cardiac bypass, pump their blood for them, oxygenate the blood, put it back in until the beta blocker wears off. Okay, and I've had one case in my career of a severe beta blocker overdose that we got to in time enough that we put them on full bypass, coded them a few times in the cardiac lab while they were accessing all the veins and arteries for bypass, once we got them on it, they were able to cycle the meds and survive.
Are the overdose levels pretty high where I think of geriatrics of, I'm supposed to take it in the morning. Oh my gosh, I forgot. So I took one again at 10.
No.
Like, does it have to be quite a few of these for it to be an accidental overdose?
Not as many as you would think. But typically if this is a patient who, oh, I can't remember if I took it in the morning or not, then they accidentally take a second dose. That patient will usually call 911 because, oh, grandma passed out when she stood up from the chair.
Good. Yeah.
Her blood pressure dropped or her heart rate's too low and she's fainting. That's the typical accidental one pill overdose. But it doesn't take a lot of beta blockers or calcium channel blockers to kill somebody. And so these are very effective overdoses, okay, very dangerous. And this is not one I'd mess around with on scene if you're thinking it's a beta blocker overdose, because you're not going to do anything to fix them. Anything. We can try gastric decon if it's within an hour or two, maybe, but that's again if the patient's awake.
Hospital, right?
Yep. If the patient's awake and talking on scene, you can give charcoal. Sure, why not? The gastric decon is again giving charcoal, but that's again if your airway's intact. But typically you're thinking, what are the effects of beta blockers? They treat hypertension and they slow your heart. Calcium channel blockers purely slow the heart rate. And again, I point back to the cardiac action potential we talked about, where it's sodium, potassium, and calcium. So calcium channel blockers can really screw with your heart's electrical activity, really prolongs that QT interval as well, okay? And heart block is one thing we see with the sodium channel blockers. So with the beta blocker overdose here, we got a pulse of 68, a blood pressure 107, a little low, not horribly scary. The rest of our vital signs look pretty decent. Carbon monoxide, we got a 1.0, interesting. So
only going to get that in the hospital.
Yeah, exactly.
You're not going to get that in the field.
So a sedated individual, she's young, but she's sleepy. Her eyes are 4 millimeters, sluggish to light, but that's again pretty normal, especially for being kind of out of it. Respirations are pretty unremarkable. Cardiac, she's decent pulses, probably a little low at that blood pressure, but you can still feel them. The whole tremor thing, who knows what that's from? Is it she's anxious about what's going on? She's a little fainty, her blood pressure's low, she's tremulous, who knows? GCS less than 15, around 12 is like something's going on here. That's in that kind of altered stage.
Well, here's what I like about this, right? Let's get real. All of us have been on this call before.
Yep.
Law enforcement would have already given her probably 3 doses of Narcan.
With no effect.
Right, because she's going to be unconscious, sluggish, not picking on law enforcement, but they're going to throw Narcan at this. And then we show up and we even get trapped into this. Oh my gosh. She's unconscious. Well, if you look at her respiratory rate, this is not an opioid. If you look at her eyes, this is not an opioid.
Nope.
If you look at a couple of these, this is not like, don't get caught into that bias of, oh, let's give some more Narcan. Maybe it's carfentanil she needs. No, look at her respiratory rate.
Yeah, it's the classic anchoring, right? You roll up on scene in your brain and have the cops and everybody's like, oh, it's an opiate overdose. You are stuck.
Yep.
Unless you're such a good provider to take a step back, calm down, use your clinical experience to go, I'm going to evaluate this patient and use my brain and make some clinical judgments about
no
this
bias.
is or this is not. You don't have to know what it was. It's just to know maybe what it isn't.
Yep.
That's sometimes
don't bandwagon.
Yeah, that's sometimes all we can do for our patients. We don't have to diagnose the problem. It's being able to cross off the things it's not. It's that whole differential. That's why we always, ask people, hey, what's your differential? Because we want to know if you can rule out the things that it's not.
Right.
And so I don't expect people to make diagnoses all the time. Honestly, 50% of the time, if you can make it, great. Otherwise, just be able to rule out, hey, this isn't something that's going to kill them, and I can chill out a little bit. So the patient's moved, well, really lifted because they're kind of altered. Into the store, you try an IV, the deterioration, just the mental status just tanks, okay? Poison control's contacted. Hopefully, while the mental status is tanking, you're getting ready to do some airway stuff. Then she begins seizing. And again, remember, she has a seizure disorder. So is this her seizure disorder, or is this a part of the new problem? Is her brain anoxic? Is she seizing from that? Who knows? She's given Versed because of the seizure intranasally. Ambulance arrives on scene. Patient's transported by ambulance to the ER. Okay, she gets a nasopharyngeal airway, bag valve mask, assisted, an IO is established. I mean, this lady's tanking. And then the patient declines asystole. Okay, ambulance stops to do CPR. What do you think the odds are, if this is a known beta blocker overdose, that you're going to be able to get this patient back with any meds and any compressions you do?
Nope, this person's going to die on the street.
Yeah, you'll never get back the beta blocker overdose because there's a medication overdosed in the system designed to slow and stop the heart. Like, it doesn't matter how good you are at any compressions or pushing blood to the brain, you're screwed.
So is this one of the, we recognize in, like go back, right? We recognize early on, this is a scoop, run, go to the hospital, screw, like we're not going to sit around and try to get IVs. We're not going to spend 25 minutes on scene. Like recognition and immediate transport is
That's the question,
goal.
isn't it, right?
Yeah.
Because nationally, do we transport with CPR in progress?
No.
Never. However, right? However, are there times where you throw on the Lucas or you continue doing compressions during transport?
Well, protocols aren't black and white, right? You can bend them a little bit.
Well, and that's why you have online medical control.
Right.
Because now I'm putting myself in the position, all right, you call me from the scene. You're 20 minutes from the hospital. I've got an absolute beta blocker overdose. She said she took these medications, 20 of them, and it's propranolol. And that's what her friend saw her took. And she's now asystolic. And she kind of was bradycardic, more bradycardic hypotensive. And I'm thinking, wow, you're right. This is beta blocker overdose. We're doing compressions. She just went down. We're 5 minutes from the hospital. Do we want us to transport? I'd say, yeah, actually do, because basically we're just going to keep doing compressions, maybe try to get her on cardiac bypass and let the machine take over and see if she wakes up in a day when the beta blockers are out of her system. That's the only way to save these patients, is to do full-on bypass. There's things like glucagon you can try. Is that going to work? Probably not.
BB gun at a freight train?
Yeah, it pretty much is. It's a BB gun at a freight train, okay? And so unfortunately for her, she's seizing and she's got trismus, meaning the teeth are clenched shut. And so you couldn't get the endotracheal tube down. Gave etomidate, succinylcholine. That all sucked. It wasn't successful, and i-gel shoved down, okay? So then they put the Lucas device on, okay? Oh, I didn't know this was gonna happen, interesting. And patients transported with ongoing ACLS, so they just continue doing compressions via the Lucas, screw checking pulses, we're just gonna keep pushing, right? And bunch of epinephrine given. Is it gonna matter with beta blockers in there? They're literally blocking what you're trying to do. So the epinephrine can't even do its effect. So hospital course, patient's in asystole, i-gel is pulled out, she's re-intubated, given one epi, given a bunch of bicarb calcium, and died, okay? The only thing that's gonna save this patient is somehow pumping blood for her over the next day or two until the beta blockers are out of her system. If you can make that happen, great, you can potentially save her, but if you can't, she's dead. So it's a tough case.
All right, here's another medication. Last one, recognition. You can recognize medications that are calcium channel blockers by the suffix. Is it LOL, pine, itis, or ology, basically? So this is your calcium channel blockers and recognizing them.
This is a tough question. This is too hard.
Too hard. Come on.
It's too hard. It's too hard for me.
Well, that's saying a whole lot.
Because I can tell you the classic calcium channel blocker that we give.
And it's not, does not end in ipine.
Bingo. Bingo, because the classic.
What is the medication?
Diltiazem.
Weird.
Yeah.
All right. Well, 55% of the people, and they got it right, so it couldn't have been that hard. So, let's see here, 48% say pine, or it would be ipine. LOL is your classic beta blocker, not calcium channel blocker.
Correct.
Itis is inflammation of something, and ology is a specialist of. So, So, just was a little fun fact to throw in there, mostly because as EMTs, recognizing medications I think is important. So if you can start to get some commonality of groups, that's fine. But Dr. Dersh is going to tell me I'm full of shit.
Is in there.
Yeah. Go ahead.
So we got our So see, you got the
look, the examples given.
Amlodipine. Yeah.
Look, see, I'm not full of it.
But yeah, diltiazem's in there as well, and some of the Zems we use.
I don't see those on here.
Yeah,
weird.
It's interesting.
Yeah,
okay,
strange.
So beta blocker ends in LOL, atenolol, metoprolol, everything. So yes, and then you can have some issues with hypoglycemia, which is why in a beta blocker dose we throw glucagon at them. Antidote, technically glucagon, it's not an antidote. It tries to reverse some of it, but it will not act as a true antidote to a beta blocker overdose. And then it's likely not going to respond to anything you throw at them in regards to epinephrine and whatnot. Then the calcium channel blockers, the classic amlodipine and whatnot. So you have so here's the trouble. So you have your dihydropyridines, okay? And then your non-dihydropyridines. So the non is what people are classically used to that we use for rate control with atrial fibrillation. That's why people are used to them. You do see calcium channel blockers that are dihydropyridines, the DHPs, in blood pressure control. And so that's why people get confused, because there are two classes of calcium channel blockers. Two classes, and they have different ends in them. So you have the diltiazims and the verapamil, which makes no sense. But the most common calcium channel blocker people are going to come across is diltiazem, which people are on for atrial fibrillation. It's okay. The amlodipines is kind of a classic blood pressure medications, but more likely people are going to be on beta blockers. Okay. The reality is, just bring the pill bottle in with you. That's the nice thing.
Or I don't know if you're familiar with Epocrates, which is an app you can get on your phone. You can look it up.
I use it.
And it's a great tool because it tells you exactly what you need about the medication, what class is it, side effects, and it has a reverse pill identifier where you can actually put in what the pill looks like, and it will tell you what the pill is for those lovely people who take the pill out of the prescription, put it in one of those Monday, Tuesday, Wednesday, Thursday little containers.
Now I use Epocrates all the time in the ER. It's like my go-to app for meds. What also is really cool, if you have the time to do it, is to put in the patient's medication list in the interaction check. So while
and see if multiple medication polypharmacy.
Yeah, maybe they're on one medication where there's really no side effects, but they're also just got added another medication 2 days ago, and nobody checked them. And when you put those two together, they cause massive side effects or altered mental status. So it's really quite interesting. So your next case is a 26-year-old male who comes to the ED, or presents by 911 with persistent worsening of the last month, no longer responding to oral over-the-counter meds, okay? 2 prior ED visits with neurology follow-up where he was told it may be related to stress. Past history, I mean, this is a 26-year-old male, so not a lot of past big medical problems. He gets some headaches, depression, some chronic back pain at 26. Interesting. Meds, surprisingly, on amitriptyline, which, remember, this is a tricyclic antidepressant for his depression at 26 years old. Wow. And diphenhydramine. QHS means before bed, at night before bed.
Is he using it to sleep better?
Yep.
Good enough.
People will take it to knock them out and go to sleep.
QHS means just before bed.
Before bed.
No kidding. Yep. Good to know.
I forgot the Latin. Q is like some blah, blah, blah. Social history, cabinet maker. No tobacco. I don't know the cabinet maker. Interesting, okay?
What does that have to do with it?
Oh, maybe it's interesting.
That's a pretty stressful job.
So blood pressure, pretty unremarkable. I mean, for a 26-year-old, depending on his body habitus, that's fine. He seems well nourished, no acute distress, skin, dermal thickening with fissures over the hands. He's a cabinet maker, right?
Weird.
Okay, great. Neuro is non-focal, everything looks okay. The remaining exam is unremarkable. Labs here, the CBC, LFT, so basically CBC is your hemoglobin, how anemic you are. If there's signs of infection, LFT is your liver function studies, okay? We don't care about that. Carboxyhemoglobin, if you're a smoker, it's up a little bit, most people.
Is 2.8% up?
No.
Oh, okay.
I mean, it's just mildly. I mean, it's like it's registering. Okay, so his social history, he frequently uses lacquer thinner because he's a cabinet maker.
Right, he doesn't huff it.
Yeah. Doesn't use protective equipment because a lot of these old school people don't. Okay, not a lot of PPE.
How old was this guy?
26, but
he's not an old school guy.
But what if you worked in a cabinet shop and were apprenticing with all the people who have been doing this for years, and they tease you for wearing your PPE?
No, he doesn't do it because he wants to get high.
Yeah, maybe. So you check the MDS sheet, okay, for the spray, and he's using 70% methylene chloride. Well, what the heck is that? Best thing you can do, call poison control.
The MSDS sheet will tell you.
Okay, yeah, it'll tell you what the effects are, what the side effects, how to clean it, how to decon it. All right, so carboxyhemoglobin levels pretty darn high, 35 minutes after leaving work, now up to 21% from 2%. So it went from pretty normal, you're a smoker, to holy crap, this is not normal. Okay, so this patient's actually treated with hyperbaric therapy to try to get some of that carbon monoxide out, okay, and everybody's called.
Which in the pre-hospital setting, we have no way of measuring this, right? Because our SpO2 is not going to see it.
No.
They do have it's called like the RAD 57 that does give an SpO2 reading with a carbon monoxide reading.
Yeah, the fire department has cool tools. I don't know.
Yeah, so I don't know if this would pick up on that. I would assume it would. This is an SpO2 that clips on the finger and gives you 2 readings. It gives you an oxygen reading and it gives you a CO reading. And it looks just like an SpO2. It's called the RAD. I think it's called RAD 57.
I need to look this up.
It's a big red device, looks just like an SpO2.
Because it's still a colorimetric measurement.
Right.
Which is what
the O2 monitor is. It's light transparent through the finger. That's how it works. Check it out.
All right, I'll have to look at how accurate these things are. So carboxyhemoglobin, typically this is an inhalation exposure. This is the person asleep in the car, that kind of stuff, okay? Or classically in the winter, we see it with people still trying to grill out, and they grill in their garage, or
Right.
they're running a generator in their garage trying to do some garage work.
Or even like poorer populations of bringing the generator closer to their house.
Yep.
And it's the exhaust is getting inside the house, or we have heard of those internal heat sources as a use, right?
Yep.
Charcoal grill in the house to stay warm, putting a generator in the house to stay warm. Those are all, especially in some of those rural environments.
So the carbon monoxide binds to hemoglobin. So if you think about hemoglobin, the point of it, all these red blood cells, is to carry oxygen. We call it the box cars, you know, that kind of stuff. But your red blood cells have an iron in there, an iron molecule called hemoglobin. Heme meaning iron, globin. Okay, so it binds oxygen is the point of your red blood cells, and they carry oxygen to your tissues in your brain. Carboxyhemoglobin, okay, or carbon monoxide binds hemoglobin far better than oxygen. Methylene chloride, it's a solvent, okay, it's part of the paint remover, furniture products, cabinet shots, okay. It converts to carbon monoxide is the problem. And then you get a carbon monoxide exposure. And so we do the things that we do for carbon monoxide. We put them on as much oxygen as we can. We do hyperbarics, and we get them the heck to the hospital pretty quickly, because there's not a whole lot we can do on scene for carbon monoxide exposures, okay, other than decreasing the exposure, number one, giving oxygen, number two, but it's probably not going to change much. It's pretty tough.
We do talk about smoke inhalation a little bit, because that's probably the second most common time we're going to see this presentation is smoke inhalation post, enclosed space fire or something like that.
So the typical symptoms of carbon monoxide exposure, you're going to see under the CNS category, central nervous system, you're going to see dizziness, headache, stupor, they can't walk right, they're ataxic, they're wobbly, confused, all the way down to coma, and they're out cold. Okay, they could seize, sure, but basically you're thinking, I'm not getting oxygen to the brain. Well, what does the brain do when it doesn't get oxygen? It starts to get stupid, slow, tired, sleepy, and then coma. So it makes sense. Carbon monoxide can definitely cause some GI stuff, vomiting. Because you're not getting oxygen to your brain, you're also not getting it anywhere else. So you can get chest pain because your heart's not getting oxygen. You start to get tachycardic because the body's saying, dude, we need more oxygen. So it starts to kick stuff up to say, let's deliver more. Obviously, they're going to feel like they can't breathe. They're not getting up oxygen so they can breathe faster. You're going to have some tachypnea and stuff. Okay, and then basically oxygen's not getting anywhere. So all your organs are suffering. Vision's going to go out. People are going to think in the differential, oh, this is a viral syndrome, gastroenteritis. Okay, there's lots of things you can think of. In the world of differential diagnoses, though, virtually every time on any patient, you could add an exposure or an overdose to the differential.
For sure.
Especially
nowadays.
Yeah, every single altered mental status has the potential to be a toxic exposure. So the treatment for this is obviously start as much oxygen as you possibly can on scene. You're basically trying to win the battle and overcome Connor by just bringing in more fighters. So give as much oxygen as you can. The half-life at room air is 300 minutes, but if we pump oxygen and get them up to the higher pressure we can get of oxygen, we kick the butt out of the carbon monoxide and shove it off the cells. So if we can get them at 3 atmospheres, which is like we're bumping up the oxygen pressure, maybe CPAP, maybe get them hyperbarics, we can try to push some of that carbon monoxide off.
So maybe CPAP would be a good option. As
Absolutely,
BLS,
try it.
CPAP might be a good option.
Why not? Okay, it's basically getting as much oxygen in with a little bit of higher pressure.
Now, would you recommend our rural agencies, would you bypass a non-hyperbaric capable hospital to get to a hyperbaric capable hospital if we're in a realistic time frame?
So first it's, do I need to activate air medical?
Okay,
if I have a carbon
the weather's
monoxide.
terrible.
Okay, so now you're transporting.
Yep.
I get the person in there, get 100% oxygen going, whatever I can, and now in transport, call ahead, get online medical control and say, here's the situation, where do you want me to go?
I like it.
Because they may say, hey, we have no hyperbarics here, but the neighbor does.
Right.
And so I'm going to actually help you. I'm going to call over there. Let's get you there and see if we can get things treated. But yeah, hyperbarics with carbon monoxide is a good tool, and every city is not going to have hyperbarics at all the places at all. Usually there's like one place with it.
And with a CO presentation, do they get an obvious sign like cherry red lips?
They can.
Is that a tall tale sign? Is that like a late sign? Is that like a okay?
Cyanide and stuff like that? Yeah, no.
Okay.
I wouldn't rely on that. Basically, it's the history, and you examine what you're getting. So this is showing that oxygen dissociation curve. And so basically fetal hemoglobin, binds oxygen even better than adult. Carbon monoxide binds it better than both. You don't need to remember all these graphs. It's really cool technical stuff. Okay.
It looks so cool on a slide.
Yeah. Smoke inhalation with all you firefighters out there, and there's a lot of them. Okay, this is a very unique exposure, and you can get problems with your hemoglobin because of your exposure to smoke and combustion materials.
Or even the patients we're pulling out of the house
Oh,
fires.
yeah,
Because we have our self-contained breathing apparatus
Oh, they're totally loaded.
for sure.
And not just that, but they've been exposed to every other horrible combustion
Cyanide,
chemical.
all
Oh,
that.
yeah.
Yep.
So this is when you're pulling out your other kits, okay? Not just your oxygen. You're doing your cyano kit on some of these patients. We've had firefighters who need the cyano kit. So if you have it available, this is where you really pull that out. If you have people with chest pain symptoms, they can't get air, the cherry red lips potentially, they're confused, they have tons of chest pain, they can't breathe. This is when you pull out your oxygen and your cyano kit if you have a really significant combustible material exposure. All right, and this we just talked about this. Anytime you have burning
It's bad stuff.
there's just the worst stuff when you start lighting everything on fire. And a lot of the firefighters will know this better than I do. Okay, I just know that if you have somebody out of a fire, especially a house fire where there's plastics and chemicals and junk, that you got two main problems: carbon monoxide and cyanide.
Yep.
Because those are the two things we can fix. Can I fix acrolein? No, I can't do. I don't even know what to do for acrolein. Okay, I don't care about acrolein, but I know that I can give a cyano kit and I can give oxygen and I can do potentially hyperbarics if I have the right place for it. And so, do you need to know all these? No, just know that there is some really nasty shit in a house fire. And if you're exposed to it and you start to have any symptoms whatsoever, seek help right now. Cyanide's interesting, and a lot of the firefighters know this better than I do, okay? It has some of the same effects. It basically can bind the hemoglobin, blah, blah, blah. Okay, you can't get oxygen, and you need a way to get the cyanide off. And so you give a cyano kit, and the gist of the cyano kit is the first medication goes in and binds the cyanide. The second one helps you excrete it out your urine. So the urine will change colors. It's kind of cool. But it's a very effective, it's a true antidote, the cyano kit. Management, everything's ABCs, and then have a heightened suspicion for exposures, okay? Early airway management's key with any patient contact. It doesn't matter if there's stroke or an overdose or a smoke inhalation patient. If their airway's compromised, manage that first and foremost. If they have a pulse, great. Think antidotes if you have suspicion for exposures in any way. Again, the carbon monoxide, kick its butt with more oxygen. Hyperbarics if you can get it. Methemoglobinemia, you can get methemoglobinemia actually from giving too much nitro, if you can believe it. Yeah, it's kind of interesting. So people who overdose on nitrates can get a methemoglobinemia, where basically it's the same thing, where the hemoglobin can't bind the oxygen as well. And cyanide, just talked about it, another thing, 100% oxygen by mask, and then cyano kit if you got it. Again, total geeking out, a lot of science about how cyanide works and blah, blah, blah. You don't need to know that. Hydroxycobalamin is basically part of the kit. It's what happens. We give the vitamin B12. That's the main component of this. It crosses over the blood-brain barrier, binds cyanide, and then the next medication, it then becomes cyanocobalamin. And
it's an ALS skill only, right?
Oh yeah, the cyanide kit is basically the ALS unit should have it. Most fire departments, like especially the urban ones, will have a cyanide kit available. In the rural setting, I hope you have access to it, because I mean every fire department should have these. They do expire, which is a problem, and they're super rare to use, but when you do need it, boy, does it save a life. And this is again the cyano kit.
The only ones, the one I've seen, it comes in like a glass. It's like a glass bottle.
Yeah,
that's a giant pain in the ass.
Yeah, well,
right? Like that's a terrible idea. It's not like, it looks like an IV bag, but it's a damn.
Yeah, and the
glass
cyano
bottle.
kit has little ampules.
Oh, okay, that's good.
So these are the little ampules. Okay. But you give them in order, and the kit walks you through it of give this one, then give this one, then this one, and it's all IV. The side effects, you don't have to worry about side effects with the cyano kit. You're not going to cause side effects with the cyano kit, so it's better to give it if there's question of a cyanide exposure, and not worry about it. Okay.
Maybe this could be a BLS skill. Yeah. Maybe. I mean,
truly. I mean,
why not? Right?
Well, you need an IV. That's the trouble.
True, but like in some states, EMTs can do IVs. So
yeah. So there should be no reason you shouldn't be able to do this. If you are in a place where you're BLS and you want access to this, absolutely go to your local county and say, hey, why can't we have access to this? And as long as you can do IVs, that's the thing. So if at your local county level an EMTB can't do an IV, you're kind of out.
I think I'm going to write my medical director and see if my agency could do that.
If you can do IVs, I don't care.
Oh, weird.
And remember, the gist of it is you got the B12,
right,
which is a cobalamin. It binds cyanide, so you got cyanocobalamin, and then the thiosulfate basically helps you pee it out your kidneys. So it's basically a bind it and then help it get out the door. So
Summary, nice
in,
work.
in summary,
In summary.
don't rule out exposures or overdoses with any patient contact where they're not acting appropriate or comatose or anything where you're like, this patient's not right. Always have scene safety and protect yourself first. Think of decon. Supportive care is your basic care for most overdoses. It's time. They just need time. And if that means during that time you need to support their airway, the hospital needs to support their blood flow, whatever it is, you need to buy time for that overdose to get over with. And there are some where you can give an antidote or a medication that can kind of act as a reversal. Keep those in mind. Don't hesitate to call poison control and online medical control if you have any questions. And please, by all means, bring in the medication bottles you find on scene so we can try to figure out and play detective with you. That's really all I have.
It's very black and white.
It is. It's
Super straight.
extremely,
Super
it's
straight.
extremely straightforward.
Yeah, I like it.
Yeah.
So I'll be monitoring the question box to see if there's any other questions. Those of you that are EMSconnect users, head over to emsconnect.org. Head over to EMSconnect and you can take the CAPSI survey, not required by us, required by CAPSI. Let us know what you think about the course and then take the test. The test is uploaded. Please make sure to check the quick fact sheet. Our winner, ready for this? I'm going to randomly select Ashley Barr.
Ashley,
Pretty sure it's Barr.
wonder where Ashley's from.
B-A-A-R.
Was interesting.
Ashley, you have won our Amazon $50 gift card because you are still attentive and it is at the end of the lecture. So congratulations,
Thank you,
Ashley. We will reach out to you and we will get your contact information to mail you out one of these wonderful Amazon gift cards. Ashley, if you're listening, which you should be, shoot us in the question box where you're from. I think it'd be kind of fun to see where you're from. But if you need to reach out to us, info@emsconnect.org or our website, www.emsconnect.org. If you're not a member, follow us on social media. If you are a member, also follow us on social media, Facebook, Twitter, Instagram, selfless plug, listen to the podcast, check it out. It's awesome. And that, I got nothing else. Do you?
No.
Sweet.
Thank you.
Awesome. Have a good night. Everyone be safe.